Well, welcome everybody to Optometric Education Consultants National Webinar Series, Sunday night edition. Tonight's topic is the latest advances in eye care technology, innovations in early detection and management with Dr. Greg Caldwell, my partner. He's a graduate of the Pennsylvania College of Optometry, and he also did a residency there. He has had numerous awards. He was a trustee of the American Optometric Association. Currently, he is in clinical practice as a disease consultant in Pennsylvania. He's been involved in numerous trials, has been published extensively, and has lectured across the world on technologies, functional medicine, integrating nutrition into eye care, ocular disease, OCT, and Newsweek magazine named him one of the top 200 optometrists in the country. So with that, a nice warm OEC welcome to my partner and friend, Dr. Greg Caldwell. Greg, take it away.
Hey, Joe, thanks. And thanks everyone for being here tonight. We're going to do latest advances in eye care technology, and we'll kind of jump all over the place between instruments and different devices, and then some pharmacology here. As always, the disclosure, I've lectured for Alcon, B&L, Dompe, and Lens. I've received an honorarium. For the advisory boards, it's Dompe, Tarsus, and Envision. Received honorariums for that. I am a non-salaried affiliation with Pharmanex out there. I'll be talking about one of their devices tonight. I'll be speaking things with Dompe and Lens and so on and so forth. Just want to disclose the speakers and those affiliations. I do sit as the chairman of advisory council for diabetes and macular degeneration. I think you guys all figured out that Joe and I are half owners of Optometric Education Consultants. These two bullet points are the important ones. The content was prepared independently by me. No one's telling me what to say. I'm going to be mentioning products, instruments, devices. I'm not claiming any superiority, just experience with them. But the important one at the top there is everything has been mitigated with the powers to be CE broker and COPE. All right, here's the practice that I am in. Just like Joe and I, we're in private practice. And we see patients, and here's my office. We have 7 exam lanes. We have an optical contact lenses, and you're going to see we have a lot of fun equipment too. What I try to be is an optometric translator. Science is great. We just attended the OGS meeting when it was in Boston, the Optometric Glaucoma Society meeting, and they're growing axons and crushing them and so on and so forth. And that's great science, but we're not going to put that to clinical use right down the bat. It's going to be useful down the road, but what's the stuff that we can do for our patients and come to these education programs to see maybe something that we might want to do differently in our practice, and then we can try and make that decision. So I'm going to just start with imaging and diagnostic technologies. And just right off the bat, Joe, I have a polling question. What technology do you have in your practice? This is set up as a multiple poll. This is, just seeing if you have OCT, the traditional OCT, what we could call B scan, or the cross section. Do you have OCT angiography? Do you have an OCT that can do anterior segment? Or quite possible, you might not have an OCT at all. So just what type of technology do you have regarding OCT? OCT angiography, and you can check all that apply, and anterior segment.
Well, it is open and they're rolling in. And everybody just is saying welcome and hello. So we have nothing in the chat.
Yeah, no questions yet. Wouldn't expect that.
Well, actually, that's kind of unusual. Sometimes we have questions waiting for us even before we start the lecture. So what OCT technology do you have in your practice? Check all that applies. All right, it has gotten pretty quiet there, so I'm going to close the poll and do a display. 41% have OCT, 10% have OCT angiography, 26% have anterior segment OCT, and 23% don't have OCT technology in their office.
Perfect. And I see that the number was low on that 10% on that OCT angiography. This works a little bit better live whenever I do this live, but it's still in here. Here's the technology for OCT. Is that you have these different lenses, this lateral scanning, I just kidding you. I don't really know really how the darn thing works. And that's what this cartoon here really is all about. And that's not really important, right? That's the science part of it. Coherent light, taking all these, tissue densities. I thought this cartoon, then a miracle occurs. You need to be a little bit more explicit in step 2 here. Yeah, I'm really not sure how the unit works, but we get some really, really cool images with it. So for those that don't have OCT angiography, remember for those who have OCT, why did you get OCT really is because, when you look at the retina, was there edema there? Was there edema from, maybe diabetes? And was there an epiretinal membrane there? It was there to help us see things that we couldn't see. And really, OCT angiography does the same thing. In diabetes, diabetes is a capillary disease. So if we want to see capillary damage, why would we use a B scan? So this is just a reminder of OCT angiography. It's great for diabetes. It's good for macular degeneration, and it's for glaucoma. The B scan OCT is a little bit better. It does help me in the office as another measurement to see if things are progressing. See if, it's basically for progression. Doesn't really help me too much with the diagnosis or early diagnosis, just to help me over time if it's progressing. So just a reminder, what has changed in the OCTs is that, time domain. Back in the time when we had the Stratus by Zeiss, that was the big one on the market. The other units weren't out yet. So most people had a Zeiss. And that was getting us about 15 to 16 microns of resolution. That was doing about 10 to 15,000 scans per second. Then we jumped up to 30 to 35,000 scans per second, and we got some really clear images, clearer. That's what happens. And then we got to about 70,000 scans, and then that allowed us to get to the angiography. So basically, when you look at these images here, say 10 to 15,000 scans per second. Now we'll jump in here, the spectral domain in 2006, you can see it much clearer. It's because we were getting about 30, 35, maybe up to 40 in some instruments, and about 40,000 scans per second. But it really took, because I had people saying, well, we're doing this, just flip the switch. The instruments didn't have the ability back then. If they had a 2008, when 2014, they thought, a lot of the optometrists like, it's just in there, turn it on. Well, you had to have a unit that could scan at about 70 to 80,000 scans per second to be able to get these angiography. So it's really the scans per second. And if you start talking to some of these manufacturers out there, they're up to 120, 150, 200,000 scans per second, able to see really the whole image of the eye, the retina in really good detail. So the future with these instruments that are out there. But I want to focus on angiography really for the fact that the code 92137 has really brought angiography back to life. And I'm sure these are going to change in 2026. Maybe we'll get a practice management talk in 2026 or at the end of 2026. But I just wanted to bring it up because there now is a code. There was reason why people didn't do it was because they said, oh, I couldn't get paid for it. Well, now we can. So I like to ask, I guess I could have made this a polling question. Does OCT retinal angiography require an injection, or does it not require an injection? So it's always confusing. I'll do a whole 2-hour lecture on OCT angiography. Hammer it that it doesn't require an injection. It's basically all these scans that we were just talking about, at least 70,000 scans per second. And what's moving are the red blood cells in there, and it's able to track and subtract out what's not moving and be able to see the code. So it's movement versus not movement, and we're able to see these capillaries within the retina.
And Greg,
So,
just to make
yep.
a quick clarification, you used the term B scan a little bit earlier in reference to the picture. And I think some in the audience may misinterpret it when they hear B scan. They think B-scan ultrasound, and those are using the same name for two different things. Because somebody
Yep.
asked, what's the advantage of B-scan over OCT for glaucoma? And really, it's the image that we're looking at on OCT is called the B-scan, but we're not talking B-scan ultrasound.
Yeah, I'm just, yeah, thanks for that clarification. Sorry for that confusion. It's just that, when we say OCT angiography, I guess I could just say OCT, but I'm referring to, OCT looking like a B scan, but it's using the coherent light. So right here, this one I would call B scan. This is angiography. Joe, thanks for help with that clarification. All right, so it does not require a dye. It's just, 70,000 or more scans per second. What's moving, the red blood cells, the white blood cells, and it's able to track that and be able to see where the blood flow is. So it's non-invasive way of measuring the retinal vasculature and maybe, down to the choroid. So when we talk on phos, OCT, A slabs, when you look at the retina, you have the inner retina. So a little OCT, a little retinal anatomy. The inner retina has the blood vessel flow. The outer retina so that's compact. The outer retina is compact. That's where basically the photoreceptors are, starting with the myoid zone, which has the Golgi apparatus and the endoplasmic reticulum. Then the ellipsoid line, which I always say is the Caldwell line. Why is it hyperfluoresce? Is that it's basically the mitochondria of the photoreceptor. The photoreceptor is a cell, so mitochondria, Golgi apparatus, endoplasmic reticulum, getting to the outer segments there where the discs form and the rhodopsin and where that is. Then that gets up against the RPE. That's all tightly packed up, until the inner retina, outer retina, and then there's a loose space between the RPE, but there's also a loose space between the inner and outer retina, and then we get to Bruch's membrane. So you can see here in this inner retina, what we're trying to highlight is this is where the capillaries are. This is to me where diabetes, this is where it shines, and I'll show you some examples of that. And then, so the inner retina has these two layers or multiple layers but it's the capillaries of the retina. Then out here where the photoreceptors are, shouldn't really be any blood in there. That's just all just cells. And then, photoreceptor cells, again, mitochondria, endoplasmic reticulum, Golgi. And then down to choriocapillaris, it's pretty much a bloodbath. So it's white, black, and then the two layers of blood vessels when you look at these images. So down here, what we're trying to correlate with is these two images here are in the inner retina. So we're talking up here where these two superficial and deep plexus are. Again, this is perfect for diabetes, seeing the capillary dropout. Getting out here into the outer retina, that's where the photoreceptors are. Dense, no blood flow, but that's okay because we're sandwiched by, the blood vessels of the inner retina and then the choriocapillaris down below. So we don't really have to worry about the RPE and photoreceptors. There's plenty of nourishment there coming from that. So the two vascular in the inner retina, photoreceptors, and choriocapillaris. So where does OCT outperform, or OCT angiography outperform OCT? I mentioned it, diabetes, macular degeneration, and it's pretty good in glaucoma. Like this one here, this is a choroidal neovascular membrane starting. You can see that there should be blood flow out here in the choriocapillaris, but then this drusen-like area starts to become vascularized. The inner retina is going to light up, the outer retina is not going to light up. It's pretty good for glaucoma. Like I said, it's okay. You could see the dropout, but we probably see things on the nerve fiber layer and GCC. But we'll go through some examples of diabetes. Now, this is an old slide. I probably should just cover this up where it says, the normal eye. There's really no normal number for the foveal avascular zone. This is one of the areas where you would say that it's probably one of the most vulnerable areas where diabetes would show up. Because if you think of this area right here being avascular, then it becomes vascular. This is one of the thinnest areas of capillaries, and then it becomes thicker as you go nasal and temporal from the foveal avascular zone. So this is thought to be, in a sense, proven to be one of the more vulnerable areas. So what we're pointing out here is you could do a dilated exam on this person. You could do your traditional B scan or just traditional OCT, and you would tell this patient that they don't have diabetic retinopathy. But this retina here is this retina here. You could see the capillary dropout and you could see the microaneurysm right here. So there is diabetic retinopathy. So you might write the report or tell the patient, hey, look, you have diabetes. And luckily, with my technology, it's kind of way I, wouldn't say it to them this way, but kind of here with my technology and maybe my B scan OCT and the capabilities that I have, I'm reporting that there's no diabetic retinopathy, but if we had angiography, and that's why I say, it really, really shines here looking at that um, capillaries and that foveal avascular zone. So I wouldn't go with normal. I'll show you in some examples here how we do it. I have the OptiView, which is now Visionix. These numbers here are not on all OCTs. This is one of the reasons I kind of stayed with them. I'm not claiming any superiority that's out there. I just get the question like, hey, my instrument doesn't do that. I don't think any other instrument other than the Visionix or OptiView has the ability to do these metrics. That was at least as of AOA this year. I didn't get to go through the academy. It was too busy for me lecturing and then all the other work that I was doing to stop at all the OCT boosts. But at least as of AOA this year, I believe it was in Minneapolis, that I got to get there all around. And the only one that still had the angiolytics was Visionix. But you can still interpret them. I've seen the other instruments and they're good. You have to put a little bit of spend a little extra time. My point is here, the blue lakes is capillary dropout. So you can see you can see that this retina is becoming more ischemic. The capillaries are dropping out. The foveal avascular zone is expanding. Down here in these B scans that I've been referencing in this traditional OCT, remember I mentioned that the capillaries are in the inner retina and the photoreceptors are here, and there's this loose space in here. This is where, when the leaky blood vessels start, when the capillaries start to leak, you look kind of in this area for the diabetes, whether it's an exudate or some fluid. That's why it always kind of shows up there between that inner and outer retina. My point is here, look at how much damage there has to be before you now start seeing right here in 2017 a hemorrhage or an exudate. Hemorrhages and exudate hyperfluoresce. You can't really tell which one is which. I would say those are probably hemorrhages, but you would pull out your 90 or 78, give you a little bit more magnification. Look with your slit lamp, and you would look in this area of the fovea and see if it was white, it would be exudate. If it was red, it would be a hemorrhage. But you could see that, look how much damage there is here. And if we did this, we'd say, oh, you've had diabetes for X amount of years, you don't have diabetic retinopathy. And maybe their hemoglobin A1C is running a little bit higher, but that's giving them that false sense of security. So let me just show you here. This is just a normal report that we see. Again, inner retina, outer retina, and we're going to look in this area. And then down here, the foveal avascular zone, you can see, just look for symmetry. I have a whole lecture that, what's physiologically normal, red, green, blue, yellow disease, all that fun stuff. But I'm not going to turn it into an OCT lecture, just how can you tell? I always say, look, anywhere you have something that's bilateral, two eyes, so glaucoma is usually asymmetric, cataracts are usually asymmetric, arthritis in elbows can happen in both elbows, but it's usually worse in worse in one than the other. So it's the asymmetry that I like pointing out. And the eye is very symmetric between the eyes in the measurements when it comes to OCT, unless there's a huge refractive error naturally, not by having intraocular lens where someone would be plano, maybe a -5, but if they happen to be plano and -5, you might have some variations. But if they have equal scripts, things should be equal. So what I'm pointing out in the area of the foveal avascular zone here, again, don't try and go by normal. I've looked at these now for 7 to 8 years, and it still holds true. And that's why I had them put these kind of subtractions in when I was working with them when it was OptiView. I don't work with them as closely now as Visionix. We just recently started those discussions. But here, 19 and 21, I would say that's a 2 difference. I don't start scratching my head until there's a 10 difference. And then it's the one that's usually larger because it's usually dying and expanding. And let me just kind of show you through some examples here. So here's a patient with diabetes, and you can look, right? You'd look at this B scan all day long. Remember, these are blood vessels. So this is the vertical cut. So whenever you cut horizontally, you're not hitting any blood vessels. When you're coming down, you're going to hit some blood vessels. So that's a blood vessel, blood vessel, blood vessel, blood vessel. It's in the very inner superficial retina there. But if you look at this, you're not going to see any diabetic retinopathy. But if you come down here and look at the foveal avascular zone, there's a 35, there's a 20. I know it's 0.35, but 35 and 20. So there's a 15 difference. It's the one that's larger is usually the one that's pathologic. And when you come over here, you can you can see, look at this area out here of dropout. See, it's a capillary disease. Capillaries are dying, and they're actually dying in the foveal avascular zone, and it's expanding. This patient has diabetic retinopathy. I was the third party chair for 20 years for the Pennsylvania Optometric Association. Met with Highmark Blue Cross Blue Shield, met with Geisinger, met with Medicare, met with Medicaid. All five of those entities said, yep, why would you not call that diabetic retinopathy? If that is, a patient with diabetes and that's the capillary dropout, and you're saying that that's, diabetic retinopathy, that's how you bill it, right? So there's a patient with diabetic retinopathy. But before I had this technology, I was calling these patients, diabetes free. And I'm going to go a little bit quicker here because I want to get through some of the other technologies. So you can see here again, I have case after case. And again, you look down here and it says 29 and 39. So it hit that magic 10. And then you come over here and you can look at the retina and you can see that there's capillary dropout. Now, here is a patient, again, remember I said it's great for diabetes. I love it for diabetes. And for macular degeneration, it's great to good to great. So everyone that comes in to have drusen, they get an OCT angiography. And there's no one here that would look and say that, other than this arrow being here, and I always tease, get the $10,000 package where the arrow shows up and tells you where the pathology is. But what I'm pointing out here is by looking at all this, you wouldn't, say that there was a choroidal neovascular membrane. And there's a reason why I have this grayed out. Now I'm going to take this away. And where this is right here is where this yellow arrow is. This here is a choroidal neovascular membrane. It's non-exudative. So if I would do a fluorescein angiography on this, you would not see it. And it's for two reasons. One, it's not leaking. So fluorescein works on things that are leaking. And two, it's below the RPE. Fluorescein can't see below the RPE. Remember, that's your indocyanine green. So indocyanine green sees below it. This is the patient right here. If I cover this up, this is the patient that you just saw today. And you say, oh, I'll do your 6-month follow-up. Let's keep you on your, comprehensive, supplements. Let's talk about exercise. Let's talk about sleep. All the fun stuff. Let's get your carotenoid scan. All that fun stuff we talk about with macular degeneration. See you in 6 months. And then they come back 6 weeks later and they bled. And you're like, you go back and you double look and you're like, man, there was no fluid. There's nothing there. That's because they had something like that sitting there as a ticking time bomb. And we call that occult and non-exudative choroidal neovascular membranes. Now, here's the fun part is that there's really no evidence-based medicine what to do with them. So I'm just going to shorten it up. I've worked with my retinologist. If I can document over time that these things are growing pretty quickly, they will try and get a medical necessity to put an injection in there. I've met with my retinologist. There's a couple of them that I can send these to, and they'll consider, and that's if the patient would like to have it before they bleed. I've also done some aggressive, what I call anti-inflammatory processes with the patient, meaning, okay, let's get rid of the processed foods. Let's start eating. Let's exercise. Let's get to good sleep. Let's get your carotenoid score up, so on and so forth. And we've seen these reverse or minimize with that anti-inflammatory lifestyle that's out there.
Hey,
And
Greg,
just,
if you just take a quick step back, and this is my own question, and I'm not looking for science here, just your own personal gestalt. If this person gets treated early, do you think it has a better outcome?
Well, I've seen them get treated early and disappear. So I think that that would be, yes, a good outcome. So, and I should put, I have some in my other OCT, as you know, I have 15 to 30 hours of OCTs, and I do have some where they have gone away. So,
Yeah, one would think that if you can involute it before it actually extravasates blood, that may actually have a need for fewer injections.
yeah, a lot of the retinologists never got these one because you couldn't really bill for it. Now that there's billing, you're seeing more of the retinologists. So I think there might be a little bit more science towards this, what to
Mhm.
do with these now that now that we can find them in a sense. I hate to take it always back to the billing part, but now more and more people are buying these because you can bill it. But and that's why it ended up here as the latest in bit, in this talk. So. Here's another one here that, look at all these Drews, and you might look at here and say there could be something happening, but yeah, it's not that double layer fluid sign. It's just maybe a gap or something going on, some atrophy. But there's the drusen, and then basically I'm just going to go down here and say, go across. You can see the normal blood flow. This drusen is not vascularized, not vascularized, not vascularized. This one here is, that's what we don't want. Drusen should not be vascularized. Maybe some leaking. You go into the retina and you look, I'm sorry, you go into the, where the photoreceptors are and look, there's nothing there, but go out to where that, choriocapillaris is, and you can see this net that's out there. Again, this is where I start to get that anti-inflammatory lifestyle. And then what about this one here? Not so obvious one. We could look at these all day long. This is why I run it. Who would ever think that this drusen right here would be vascularized, but it was. That's the one that I showed you a little bit earlier when I was talking about the glaucoma, the diabetes, and had them all up and said we would jump into it. And when you do a 6x6, it's pretty, it means it's zoomed out, and you do a 3x3, you can see that net there. I don't really think any retinologist, there's really no evidence-based medicine out there. Kind of stinks, right? You got to follow these things closely. Again, if they start to progress, I send this over and document, talk to the patient, and see if there's any chance that maybe they'll run a fluorescein and see some leakage somewhere and maybe treat it. I'm not sure it's below the RPE, but then these are the ones that you have and you don't know that they're there, and then they show up 3, 6 months later and they bled. So that's not a good sign when you see that drusen vascularizing like that. So, Joe, I'm going to jump to cameras here. Is there any other questions, or do you have any questions? Have anything rolled in?
No, I did ask my question earlier, and there's nothing coming in at this time.
Okay. So let's jump into this to cameras. Again, I'm lucky to have two cameras in the office. I have the Optos here, as I taking a picture of it, and I have the Aiden by Eye Care, and this is my again, not claiming any superiority. I do basically now all disease all day long. The contact lens rep was in the other day, and he just kind of laughed at me. He goes, I could tell you what this technology is, and I said, no, I want to know. I said, I'm in education. I said, if it's just, the other docs in the practice are probably going to more benefit from the talk and all the new materials and, coatings and so on and so forth. But, how would you grade this diabetic retinopathy? And I understand that there's filters and things that you can flip around and do. And when you look at this diabetic retinopathy here with the Optos versus here the Aiden, again, I'm not playing around with any photos, but I would probably now grade this one a little bit, more advanced than I did over with the image on the left. So, to me, the cameras do make a difference. There's all kinds of technologies out there between the cameras and how they take the pictures. And again, that's, a miracle occurs, but with the certain cameras, they can get through certain cataracts and certain media opacities, and you could see a little bit more of, like these different dot and blot hemorrhages, the exudation that's occurring here. To me, this is a more ischemic retina. I would grade this more ischemic than I would over here. And that's really what diabetic retinopathy is. You're just grading the amount of ischemia. And then when it gets too ischemic, you get neovascularization of the disc and elsewhere. Again, another patient with diabetic retinopathy. Here's the camera. And then you take it with this. And now these areas certainly show up really, really easy. Maybe you play around with some filters. You can definitely see different hemorrhages out here. I would grade this diabetic retinopathy a little bit different than I would with the image on the left. You can do some wide field imaging to take 3 pictures. It stitches them together. And you can see here, what these black hemorrhages out here in the periphery. Neuroretinal rim analysis, neurofibrillary analysis. I'm going to just go through these pretty quickly. I like to, because I got some flicker technology I want to go over. You can see here the neuroretinal rim. If I'm going to follow a glaucoma patient, I want to be able to see that whole rim and the neurofibrillary with these patients. Same thing here. It's just showing that there are differences in qualities of the cameras. You can see the neuroretinal rim loss. You can definitely see the neuroretinal rim loss that's occurring with this imaging here. Now you look at this, you'd think, okay, yeah, I can maybe see an epiretinal membrane. And again, you maybe play around with the filters. I just said, go take it, same day, different camera. And when you look here, you can see even the striations, the puckering. You can kind of just see, like right here, it's all kind of pulling in this area. You can see the striations. And then maybe you would do an OCT to see, if there's any lamellar separation, any hole forming. But you can see the different traction on this retina. Patients really understand it whenever they see that, when you explain that scar tissue. And remember, epiretinal membranes, I always kind of use them as like kind of jello. Put jello in the refrigerator after you make it, try and scoop it out with a fork. It's just going to fall through. They do mature over time. They do solidify. They do become kind of crispy. They do contract. So you can follow them over time and see what it could do to the retina. And that's what I wanted to kind of get through here with flicker technology with this camera. It's really been cool because now I'm going to just put 2 of their images side by side. And I call this, do you see it? Can you tell? And this is a glaucoma patient. So with glaucoma patients, I'm going to tell you what the 3 things that I want you to see if you can see tonight. The neuroretinal rim change, peripapillary atrophy, nerve fibrillary, or 4 things. Drans hemorrhages, neuroretinal rim loss, nerve fibrillary changes, or maybe peripapillary atrophy. And I can see the nerve fibrillary loss here and here, but is there any change to the neuroretinal rim by looking at those? So let me just kind of go to here. What this technology does is it puts them on top of each other. You can see the 2023 to 2024. Down here, I have it wide enough. I recorded the screen that I was using at the office. I have a program that I can record my screen. You can see my arrow down here that's on my computer monitor at the office. And what I'm going to do is, what I like to do is I just click, click, click. I just like to know which one is the old one, which is the new one. Then I hit play, the button on the left, and then it will flicker it. And then you can change the frequency and you get it up to 10 hertz and it really flickers back and forth. But this is a glaucoma patient. See if you can now see the neuroretinal rim change with this. So I'm just going to click back and forth. That's the new one. That's the old one. New, old. And so now I can turn it on, let it flicker. And then if you look right here, I'll get my mouse out of the way. Now you can see that that's expanding. And on this one here, you can see the neurofibrillary defect, and that's kind of right where that area is. So that was caused me to kind of follow this patient a little bit closer, maybe get their IOP down. Here's another one.
Hey,
Go ahead,
Greg,
Joe.
before you go to, somebody has something very specific. What were those 2 red patches 2 slides back?
2 slides back.
I think they might be. I know. Yeah, I think
This
right
here,
there.
like
Mhm.
here. Yeah, it's probably just a white without pressure type of situation going on. This is the white without pressure. This is the normal retina or just reflectance. So,
Very good.
yeah, that does, it's not pathology. I ran some OCTs on it, just some optical changes. You can see here white without pressure here. So it's just optical reflections, let's say. if that's the one they're referencing.
I think so.
Okay. All right, so we did that. So this is one Joe and I have always teased. Joe, I know that we've always got things at our live meetings. I'm not sure if you've seen this yet. We always talked about the peripapillary atrophy on this one. So I'm just going to just tell you right off the bat. Do you see the peripapillary? Not Joe, just the audience. Do you see the peripapillary atrophy change? And I'm telling you to look for it, and maybe you could see it, maybe you can't. And there's, a little bit over a year's worth of time span with this. Now, watch what happens when I play the video. I really love Flicker technology. I've had this in my office now. It's right down here, this inferior area. You'll see it start to change right there. And that's expanding. That's not such a great one. I have another one coming up here, grade the diabetic retinopathy on this patient. Now, this is a fun one of mine. This is, as you guys know, Joe mentioned in my bio there or whatever introduction is that I really have gotten into functional medicine, teaching these patients that this is hyperinsulinemia, get the exercise, more weightlifting, fat is a bad endocrine gland, muscle's a better endocrine gland, get their carotenoid score up. Just going at a holistic approach, just rather going, yeah, I see, moderate to severe diabetic retinopathy here. No, you don't have macular edema. Let me send a report. Let me bill your insurance company out the door you go. I try to get a little bit more into this. So he actually got better with this, and you'll see the improvements. And I think you can see the improvements here, but watch how much easier it is to see whenever you flicker these. And this person was super excited. I mean, you could see here, this is the before one. That's why I do it before, after. And now you could see, look at the hemorrhages disappearing for this patient. They had hemorrhages. They really got their act together. They were, got some, Whoop band or maybe an Oura ring to monitor their sleep. And, they're lifting. They found a trainer to help them out. And they're eating better. They committed to coming in and getting their hand scanned and getting their carotenoid score up. And when I talk about, what I've learned in functional medicine is that we try to make things too linear, right? Well, just get your hemoglobin A1C down. It becomes a strategy. So it's just not the carotenoid score. It's just not the sleep. It's just not the exercise. It's everything together when it becomes synergistic. So Flicker technology has really been fun in my practice. I'm going to just tell you again, this is another peripapillary atrophy. Can you see the I'm putting them side by side like we would do it in our office. Maybe if you zoom in a little bit, but we're kind of highlighting the Flicker technology here. Okay, let's go back. One more look. Where is it? Where is it expanding? But whenever you flicker it, you'll be able to see the change that's occurring. And it's up here, up in the superior nasal.
Hey, Greg,
side.
somebody asked if you could elaborate on seeing neurofibrillary defects on the Aiden.
What was the question about it? But what's
If you can
about?
elaborate, seeing neurofibrillary defects on this device.
Yeah, I got two cases coming up here that will highlight the neurofibrillary. We saw it a little
Very
bit
good.
in the other one, but we'll see it more coming here. But there it is, Joe, that elucid peripapillary atrophy change right there. We'll play it again, and we'll drag it over maybe and get it where I'm really flickering it fast. And you can see the peripapillary atrophy change. And I never really saw it when looking live or putting two photos side by side. It really took this. So, this was my favorite case. There's another case after this. I called it my favorite case of do you see it? Again, glaucoma patient. Is it the nerve fiber layer? Is it the neuroretinal rim? Is it the peripapillary atrophy? Is it a Drans hemorrhage that we're going for here? And this became my favorite case because I was looking for it, and whenever I imaged them and flickered them, I totally missed it on this image right here. Let's play the video and then we'll come back and show it to you. So again, there's the before, there's the after. And I think I maybe zoom in here on my screen to be able to see it a little bit easier. And there we go. And it's right here. And it's a Drans hemorrhage. Totally missed it. When I was flickered it, I laughed out loud, kind of chuckled. And the patient's like, "Hey, what are you laughing at?" And I said, "Well, I said, look, I was looking for this, and this is what I love about science and technology and whatever devices. Um, I missed that Dran's hemorrhage right there." And I was looking for it. And Joe and I teach it, and we look for it, and always look for it. And it's at the glaucoma prone zone that we always talk about: inferior temporal, superior temporal, the glaucoma prone zone, and totally missed it. But I didn't miss it the whole exam. I just missed it on the initial pass, and the technology helped me find it. A little bit hard to maybe see if you don't, if you're working off of a device here, but there's a lot going on here. Why this becomes now my favorite case. You can definitely see the nerve fiber layer loss here easily. Nerve fiber layer loss easily. Going from this picture to this picture, is it expanding? And then on top of it, I thought there might be a Drance hemorrhage here on this picture, but whenever I came over to this picture, there was that same area right there where, okay, maybe it's anatomical. So you're going to see what happens, and again, I'm just comparing it to the Optos over here and why, this technology here really helps me out in the practice. Again, not claiming any superiority, but watch what happens here. I'm zoomed in on this one. You watch what happens to the nerve fiber layer. You'll see it expanding. And this is scary because it's expanding into the macula. And then watch down here in this glaucoma prone zone, down here, inferior temporally. You don't see it here, but when I flicker it, there'll be a little dot. And then right where this atrophy has occurred, that's where the dot was, right? That's the Drance hemorrhage and then the atrophy. Drance hemorrhage and atrophy. Watch what happens when I play this. See, there's the hemorrhage right there. Hemorrhage, 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 hemorrhage. Now look at the nerve fiber layer. Look how it's expanding. It's getting the defects expanding. The nerve fiber layer is both sides. This is coming down. This is coming up. And watch, it's a lot easier to see. Look at the nerve. There's a Drance hemorrhage there. And without the flicker technology, and the reason it was there, the first picture, and I even made it in the note, possible Drance hemorrhage, but found bilateral, same area, potentially anatomical. Because watch what happens over here in this side. You'll see that the patient, when they came in and on that September 16th, 2024, I'm just kind of showing you how you can see the two and be able to tell which one you're on. And then you can speed it up. I'm just flickering it. Now I'm going to zoom in here. And if you look, there's the Drance hemorrhage right there in the same area where that one was. And you can see what's happening to the nerve fiber layer here, the expansion, and see the change that's going on. So bilateral glaucoma, you can see it's a pretty, moderate to advanced case, and it's not controlled, right? And I'm not even telling you that you do a OCT. I'm not telling you to do anything fancy. This is just plain old retinal photography that's out there, which is the standard of care, still the standard of care, because not, as we saw, 20 some percent, 23% don't have OCTs. So that's not a standard of care. It's definitely encouraged to use for managing glaucoma, but not a standard of care. And you can see what's happening with these nerves. All right. So that's enough of OCT. Let's get into some other fun stuff and get into some drugs and some other things in the next hour or so. Any questions pop up there, Joe?
No, we're good.
Okay. So, here's the Rabin cone contrast test. This is color vision, ERG testing. There's genetic testing. This is all early detection. And this is why I've gotten into functional medicine, is because when you start diagnosing diabetes or glaucoma or macular degeneration or some of these conditions, there's sometimes not a pill for the L. So like over here with dark adaptation, when you could pick up macular degeneration before Drew's in, what do you tell the patient? Well, it really stinks to be you. I can tell you that it's going to happen. No, we can start talking about, exercise and diet and carotenoid scores and sleep and all this kind of folded together to try and get them to be a lifestyle changes, anti-inflammatory, and maybe use these instruments to help the patients that are out there for us. So
Hey,
early
Greg,
to,
hey,
yep, yep, yep.
I'm going to ask you take a just a step back before we get too far forward. A late question did come in. Do
Yeah.
you find OCT, NFL, RNFL numbers correlate with the photos, or is there a delay?
No, though, if you see this atrophy, atrophy is atrophy. So yes, you'll see a change in the OCT.
Yeah, I would agree. I think you should. In fact, I think the changes may occur or be more noticeable on the OCT technology because when looking photographically, it is a fairly gross observation.
But changes on the OCT doesn't mean that it's a change in glaucoma, right?
Mhm.
Because remember, the vitreous is alive. I have plenty of OCTs where a PVD has released and the nerve fiber layer has changed. The GCC has changed. A epiretinal membrane has changed. So I can see maybe where the question's coming from, like, oh, maybe I don't need this because I'll see the change on the OCT. The change on the OCT doesn't mean that it would have to be a glaucomatous change. This here is definitely a glaucomatous change. You see the hemorrhage to the optic nerve. You see the nerve fiber layer change. Now, if you go to the OCT, yes, you'll see the change, but not all OCT changes means that it has to be from glaucoma, and it could be because the vitreous is alive and pulling and tugging and the patient's aging. So I'd be careful just saying, okay, I'm going to rely on my OCT. Not saying that's where you were going, but that's what pops into my head. But that was a great question. All right. So we talked about this, early detection. Patients are expecting it. And I can tell you the other day, I had a patient come in with all the technology that I had. I said to the patient, look, you don't have diabetic retinopathy. I got some really advanced, detailed stuff, and the good news is you don't have any. And more patients are saying, "How can I keep it that way?" Right? So that's why we have the contrast sensitivity. We've got genetic testing. We've got the hand scanner. And I've said, one, better understand lifestyle changes, or a very famous person said, one, better understand lifestyle changes, the immune system, and nutrition. Um, as we are now in the areas of where there isn't a pill for the ill for every ailment that you diagnose. And we saw that with the OCT A when we have a coronary vascular membrane. Standard of care is not to inject those. You inject them when they leak. So there's not always a pill for the ill whenever you have something with early detection. And doctors better become more like nutritionists, or the nutritionists become like doctors. And I always say, who's the famous person that said that? And I said it a little bit earlier. That was me. Those are all the quotes that I've kind of come up with, and over it's that nutrition, immune system, receptors. Sometimes there isn't a pill for that ill. We've got technology out there, and nutrition's a big part of it. So I usually ask at a live audience. I did it in Detroit, and I said, okay, which one picks up glaucoma first, structure versus function? It's a loaded question. Everyone said, oh, yeah, structure. Well, not really. In your office, that could be. When someone would ask me that question, I would say, what two instruments are we comparing? In glaucoma, if you have a Humphrey visual field and an OCT, yeah, probably 90% of the time you'll pick up, or high 90s, you'll pick up glaucomatous changes with your OCT before you see them with your visual field that's out there. So structure versus function. But what about if you had an ERG testing, or what happens if you had the Rabin cone contrast testing that's out there? So depending on the technology, so don't fall into that. That's why I put up this rock, paper, scissors thing. Always know what technologies the person is asking the question about, and that will help you. So the structure function thing can go back and forth. So polling question number 2 is,
Mhm.
do you consider color vision testing an important test for ocular disease management? Click all apply. So yes, no. And basically you do it because, as you know, if you want to pass vision plan requirements, you have to do some type of color vision testing. So do you consider it an important part of disease, not of the exam, but of disease management?
Okay, they're rolling in right now. We have no questions. I'll check the chat box in just a bit. All right, I think we're slowing down. But I think everybody has weighed in, so I'm gonna close the poll
Yeah,
and
I see
display,
it.
and the majority say yes.
Yeah.
It is important.
I guess I should have followed up with then what test are you using then for your disease management? Because if you're using an Ishihara, that type of test, there's no way you're going to be able to use it to, follow glaucoma, macular degeneration, so on and so forth. So you hear this word out there, it's kind of the new buzzword, biomarker, so IOP is a biomarker, visual acuity is a biomarker, your hemoglobin A1C is a biomarker. And can we use color vision as a biomarker of disease, macular degeneration, optic neuritis, diabetes? The answer is all yes. So the key is when you look at this photo here is that we all know that the photoreceptors is what generates the color of our visual pathway. But what we're finding out is, if we have diabetes and it's having capillary issues in this inner retina, any part of the retina involved will now start to affect as the signal comes through, the color vision testing. So damage to any part of the macular or visual pathway affects cone function. Really, maybe the cones are okay, but when it's going through the diseased neuronal parts of the retina, which is the inner retina or all the cross wiring, color vision will change. Change in color vision can be detected in early disease and is a natural predictor of pending vision loss. So functional changes often precede. So this is a functional test here, and I have this in my practice. And this is a few of us. Nate Lighthizer has it. Panak and Davi, I have it, and we're working. With Cheryl in Innova, trying to always report cases back to try and because it's an easy test to do. It's not an expensive test, and it's also reimbursable. That's out there. So for the docs out there, it's kind of like it's got everything. Reimburses. It doesn't cost a lot to have this instrument. And kind of just in general, macular degeneration often begins with red and green, so we kind of put it in the green category. And pre-diabetes starts affecting the blue, and it's not always the trend. I mean, it's not always the way, but this is kind of what we've seen. And glaucoma or neurologic starts to affect all three cone types: glaucoma, or the stuff that Joe likes to talk about, the neurological parts that can affect the eye. This is just a patient in my practice, how it's done. It's now has this is before where now it has a remote control, or like a device that you game with, handheld device that you can use. Before, you just put your hand behind it and used your thumb and touch the letter. Tons of science behind it. You had to do it in a dark room, monocular, up close vision corrected. And this patient is a glaucoma patient. And remember, glaucoma, if you go back, affects all three types. And you can see here, it's definitely worse the glaucoma is worse in his left eye than the right eye, but he has a cataract in this eye, and I think that's why it might be affecting the blue a little bit more. So all three, glaucoma, remember, is bilateral. It's worse in his left eye. I can just tell you, knowing this patient. And then I think that this was a little bit worse because his cataract was a little bit worse in this eye. Now, I already knew he had glaucoma, but what it does is it helps me over, and again, is it progressing? It helps me with the progression part of it. So I already knew he had glaucoma. It confirms it. Okay, I really didn't need it confirmed. I had all the other tests. But what this does now over time, it gives me another biomarker or another way to see if the patient's progression. I've even seen color vision improve, just like we've seen visual fields improve whenever you take some of the stress off of that retina by lowering the IOP. So it's good for macular degeneration, diabetic retinopathy, glaucoma, and retina disease. And this is what I'm showing you here is that you can track it over time. This right eye doesn't have a problem, but the left eye, there's definitely disease process that's progressing over time. Um, uh, and you can see it at the right eye, even though it looks normal here, over time it's progressed. Left eye, and it's progressing. So again, disease is bilateral, worse here in the right eye. I'm sorry, worse in the left eye than the right eye. But over time, both are changing. This eye is probably going to catch up. So it's been really nice addition to the practice to be able to use it. This is what it looks like. It just changes, and I'm gonna play it again, but then the person would just hit, H, and there's not that many letters, U, tons of science behind it. It's used by the FAA. It's one of the one or two or one of the three tests or two tests, I think it's three tests that are used by the FAA that pilots can get tested. And we do have a little tiny airport in my area, the Altoona Airport, and some of the pilots that fly out of there live in the area, and they do come in because I have this and I can clear them on there. They have to be tested yearly, and this is one of the FAA approved devices. You can see that there is a code 92283. National average is about $52 to do the test. So it's a nice little addition, multiple ways for the practice. Functional testing in diabetic retinopathy. This is kind of neat. So you have someone that has disease. Now, are they going to progress? Like, what's their risk assessment? So you saw me have this patient, and I wish I would have had that patient that got better, would have done this test, but that was a little bit before I had this test. So I would have loved to see if maybe their color vision would have improved. But if someone comes in and they have bleeding in their eyes, and you say, geez, what's the chance of it progressing? Well, if they have a functional problem with color vision, it's probably going to progress. And if their color vision is good or stable, it's probably not going to progress. So I'm not sure what just happened there, but okay, there we go. My screen split. So what we're showing here is patient with both structural and functional abnormalities are 11 times more likely to need more treatment than if they didn't. So here's a structural abnormalities, and then they had structural and function, and you can see that they progressed with structural and with structural and functional, there was a 34% chance. But whenever you go back and just did structural abnormalities and function was normal, that was a good sign that they were not going to progress. So, you can use this pretty well in the practice. And again, this is, I have some good cases, but these were shared with me. So I'll give courtesy of Becky Verna here. She's an optometrist. She shared this, and I just plugged it in into mine. So you could see basically patient with diabetes. What would be your diagnosis? No retinopathy, no macular changes on OCT. That's patient A. No retinopathy changes, no macular changes on OCT. So again, we might say these are normal. I don't know what OCT angiography would look like, but then you could see here that the color vision is being affected more in this patient B than they are with patient A here. And again, this is a sign that their retina is sick, right? And so now the next step would be hemorrhaging and so on and so forth, and we might be able to intervene beforehand. So this is a case where Nate used, nutrition. Nate and I talk nutrition all the time, even though he's a big Oklahoma guy. Out there teaching all the surgical procedures. He definitely believes in the sleep and the working out and the nutritional side. And so this is just a case where a patient came in. You could see what I'll just say a metabolic wreck, right? You could see hyperinsulinemia is the root cause. I'm building a big lecture on that, or a 2-hour lecture on that. And that's what caused not just diabetes, but the high blood pressure, the dyslipidemia. You can see hyperlipidemia here, or the triglycerides or the HDLs. That's what leads to obesity. That's what leads to the type 3 diabetes. I hate that name. That's dementia and Alzheimer. It's all one of the root causes, or the big contributors is hyperinsulinemia. And so this person is metabolically sick. It's the metabolic syndrome. And you can see the retinas look good, the OCTs look good, but their color vision does not look good. And so again, Nate on this case would do what I do, talk about sleep, talk about exercise, get them on a good nutritional plan, and you can see that their retina's improved. I'll just kind of flicker back and forth. The right eye is more impressive. Just watch what happens when I take this away. See how they're all 90s? And they were 75, 50. And basically that was lifestyle change and nutrition and sleep that helped this person out. And you could see that the retina was struggling. They were metabolically being stressed, and this device helped out. Here it is here. It's one of the 3 required tests for pilots that need to be checked. And so if you're looking for something and maybe want to market it, you live in a big area where there's pilots, maybe consider this and you can have it as a little bit of a niche for your practice. All right, Joe, any questions?
Nope, we're good.
Okay. Um, One of my passions, Joe knows I love doing this. I'm trying to introduce a little bit more functional medicine. Listen to this lecture by Paul Bernstein. He's an ophthalmologist, spent his whole life studying the macular pigment. And, I'm going to go into, this device that measures, carotenoids. And I don't really, if you had these in your practice, I had an M pod in my practice. And for years, I really wasn't interpreting maybe properly. The M pod is, measuring the carotenoids in the macula. And I was thinking, just like probably most of us, you're low in carotenoids. That's not good for your macula. That's replaced with carotenoids. But what I learned in functional medicine is that there's other devices out there and that they like measuring carotenoids because it's a good relationship to your overall antioxidant status in your whole body. And so they interpret it as okay, your carotenoids are down, and they like using the carotenoid as the biomarker because of all the antioxidants. It's stable, it builds up, blah, 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 better than polyphenols, flavonoids. And it has been proven through blood tests and skin biopsies and tissue biopsy that it is a direct reflection of your whole antioxidant system. So the functional medicine doctors like to cover everything the whole way rather than just going kind of allopathic. You're low in carotenoids, let's replace with carotenoids. So I really don't care what instrument you can really use. There's a lot out there. Dr. Bernstein was talking about, the psychophysical, which are, those are your M pods where you have kind of that flicker pattern going on. And the more carotenoids you have, you can see the flicker going on longer. There's reflectance. That's pretty much what the life meter is. And then there's Raman spectroscopy. That's what's being done over here. And that would be the hand scan. That's the one that I have in the practice. And then what's really exciting, and I just got the UPS update today. I'm getting the new one tomorrow. It's going to be delivered to my house. I've been waiting for this. They've been talking about it. And as we know, with equipment rollouts, it was supposed to be out in 2023, then 2024. And it is out in 2025. It's just the end of 2025. It's going to be able to do a finger 15 seconds or less and give a carotenoid status. It's going to do pretty much what all these other do. This one has a 20 million database. It's going to go into machine learning. It's a pretty cool database that's out there. And it was pretty funny the other day. I was in the airport and talking about this, and a person saw it on a watch, a Samsung watch. And I Googled it. And if you do Samsung antioxidant, the watch is going to now. So that shows you the legitimacy of, we have steps and we have sleep and we have heart rate variability and all these different things in our devices. And now the watch is going to, it's not a really accurate way, but I like it because it brings some legitimacy to it. The scale was low, medium, high, something to that effect. I'm sure it's just going to be there to kind of remind the patient like what or the wearer what to do. Now, here's your, carotenoids. Again, I just want to remind everyone it's a biomarker that's out there. And again, it's a good predictor of mortality, right? Not just blindness and loss of vision, but mortality. And if you get down through here, there's depression, there's metabolic syndrome that we just talked about, protection against disabilities. Here are the eye stuff that we're all familiar with within us, some cancers. And that's just because when you have low carotenoids, your whole antioxidant system is low, unless you're supplementing and maybe taking a vitamin A or extra vitamin D. But the idea through science is that when your carotenoids are low, because it's a nice biomarker, it's a direct relationship to antioxidants be low in your body. It means free radicals can take over, and now you're being pounded, and that's when the genetics can express epigenetics, your genetic SNPs, so on and so forth, and then that leads to some of the chronic diseases that are out there. So when I do this in the practice and the scale is going to change, it's going to go down to basically just a three-digit number rather than a 10,000 number or 19,000, 26,000. The scale is going to change, but it's still going to be purple is good, yellow or blue, green, yellow, orange, red. So right here, but basically this is an example of not a great high score. And inflammation, cardiovascular disease, Alzheimer's, diabetes. It's not saying that, you're going to get it tomorrow, but let that grind at your body for 5 years, a decade. And that's why we have so much, chronic disease in the United States with our patients. So you can see here that you really want people to be on, I don't care which device you use, Life Meter can do it too. You just want to get their score up. It's just that I just don't like replacing with carotenoids. I like replacing with everything else because that's where the science has showed us where to be. Like this person here is very well protected. Now it's just not linear, right? You're not done. Okay, you're eating well, your antioxidant, your micronutrients are high. How's your macronutrients? And then on top of it now, how is your parasympathetic, which is your recovery, your sleep? How is your sympathetic that's out there? So it's got to be a strategy. Basically, when your score is low, this is what it looks like. And when your score is high, there's your antioxidants protecting the cells. So cellular protection is what this is all about. And I thought this was kind of neat. This was on LinkedIn. This person here was saying, "What has nutrition got to do with brain health?" And you can see here, this would be, say, like a ganglion cell and the nerve fiber layer that synapses in the lateral geniculate body. So when we say eye is brain, ganglion cell starts in the fovea, parafovea of the periefovea of the macula. Nerve fiber layer through the optic nerve, lamina cribrosa becomes myelinated through the orbital fissure, through the chiasm, back to the lateral geniculate body. That's one long axon, and then it synapses there. And you can see here that she's like, listen, this axon needs the B vitamins, the riboflavins, over here, CoQ10, over here, B9, polyphenols, flavonoids. It needs some fish oil, the EPA, DHAs, or your essential fatty acids of the omega-3s, your polyphenols and your flavonoids. So again, this is why I think you just go comprehensive. That's out there. We really don't need these specific formulas. Here's me putting it to work. Here's a 67-year-old woman that comes to my practice. She's got rheumatoid arthritis. That's falling down here into the autoimmune disease part of this. I work right down the road from a 6-man woman rheumatology practice that's right 2 miles away. I do some of their secondary testing for them when they're in studies. I'll do, like, they do Sjogren studies, they'll do other things, and it can affect their eyes. Even when they do other biologics, it can affect their eyes. And I'm kind of their secondary person that checks off I have to go through all the credentialing. So I see a lot of these rheumatological conditions. So they do a great job managing this, but the patient came in and I said, look, your score is so low. Why don't we try and get your score up? It will start making your medicines work better. It will start overall making your cellular health better. And you can see it took a while, but we finally got her up. And she was like, man, I just feel better. They just overall sleeping better. The micronutrients just weren't there. And basically, we're kind of stacking the deck in her favor and trying to help her out. This was a 32-year-old woman that came in and she had a very low score. She had Graves' disease. We had this good talk, like, you're 32 years old, you got this autoimmune disease, look at the oxidative stress. And so she's like, just tell me what I got to do, doc. I totally get it. I know that I don't eat well, a teacher, so on and so forth. And we got her score up and she found the benefits of that. So pretty cool. That's out there to be able to do that. And there's a new device coming out. I'm just going to go through here. I'm able to get drusen disappear. It doesn't happen in everyone that's out there, but having drusen disappear, this is the before, this is the after, but it's just not the supplements. It was the sleep, it was the exercise, it was the whole strategy. And I used to say, coming late in 2020, this was what I use, but it's going to be really cool to have this out. They really changed the whole program. You don't have to lease it anymore. There's no contract. You can buy it. So it's going to be really cool to see how many eye care physicians, along with other specialties out there really embrace this. I mean, it's a $299 technology. So it's going to be really cool that's out there. But again, you can use whatever technology you want to measure carotenoids. There's a lot of them out there, whether it's the M-Pod or the finger scanners. There's other really expensive instruments. Just remember, if you're low in carotenoids, my take home is try to replace with everything because that's where the science shows. Then if you want to stack on top of it a carotenoid, I'm totally fine with that. If you look at the frequently asked questions at the National Eye Institute for AREDS 2, so if you just type into your search bar, AREDS 2, frequently asked questions, NEI, hit enter, the first one's going to come up is the frequently asked questions for AREDS 2 from the National Eye Institute. About the fourth question down, it says, can I take a multivitamin if I have AREDS 2? And the very last line says 9 out of 10 we're taking a multivitamin. So I hear people say all the time, well, show me some evidence base. Well, that's a very used study for the last 2 decades. In the AREDS 2, 9 out of 10 we're using a multivitamin. So if you're using AREDS 2, are you recommending a multivitamin? Everyone wants to use evidence-based medicine. There it is right there. So yeah, go comprehensive is my point. Any questions, Joe?
Nope, we're good.
Okay. Let's do some pharmacology. Let's get into some of the pharmacology drops. Let me just ask this question, Joe. There's a polling question. Primary
Mhm.
open-angle glaucoma. Is it a disease of inflow or outflow?
I have just opened, and for those, if you haven't found it, you have to go to the icon on the right where it says polls to see the polls.
If you're on a device, I think it pops up at the bottom, like a phone or a tablet. If you're on a computer, like Joe said, to the right. On a device, it thinks it's towards the bottom.
And they're coming in. All right, we have some people still responding. We're thinking about it.
I think the thing's still opening up. I'm going to close it for the color vision. All right, we're good.
Nope.
We got it. All right. Well,
All
the
right.
trend is there.
Yep. So the majority, a quarter versus 3/4, think it's an outflow, not an inflow disease.
Perfect. I agree. It's an outflow issue. What I want to point out with a couple of these things is remember it's the aqueous gets produced in the ciliary by anterior chamber. But I really like to drill down is don't forget that it's the trabecular meshwork, and the trabecular meshwork of a glaucoma patient is different than of a healthy patient. It becomes oxidatively stressed. It becomes tissue changes. So the tissue starts to change at the trabecular meshwork. Schlemm's canal, then there's a collector channel. Then there's episcleral veins, and it gets into the superior vein, inferior vein, comes and then eventually to the cavernous sinus. But really, I wanted to hone in on, trabecular meshwork, Schlemm's canal, collector channel, episclera. And this was some science that was presented at the Optometric Glaucoma Society, where when the pressure goes up, the trabecular meshwork herniates into that collector channel. So here's the trabecular meshwork, Schlemm's canal collector channel, and then it herniates. And when people have diseased trabecular meshwork, it becomes sticky. It's oxidized. I learned this by geeking out to someone that did a PhD in trabecular meshwork, and I had a 6-hour talk with him one night at Academy. And what we're showing here, and Dr. Freddo has shown here, is that even when you take the pressure to 0, because it's sticky and not the same, it can herniate up into that collector channel. So we know that even when if it's healthy, you got trabecular meshwork, jam it up into the collector channel, and then it's healthy, it will unpop. But when it's not healthy and diseased, it gets stuck up in there in some cases. So remember, the trabecular meshwork is sticky, it's oxidized, it's not healthy, and it can mess up that whole kind of flow in that through once it gets through, if it can get through the trabecular meshwork, Slem's canal, and collector channels. This is whenever I was a speaker for ARI. This was in their slide deck when we were talking about Notarsadil, and Dr. Epstein, David Epstein, was going for a medication that would relax the trabecular meshwork. But you can see here, a picture's worth 1,000 words. Right here, the trabecular meshwork is healthy. Over here, it's diseased. You can see why maybe we want to target the trabecular meshwork. Interventional glaucoma is about basically trying to use the minimum amount of drops that's out there using lasers, early surgical procedures, lasers, and maybe drug delivery systems, because the most gratifying things that I've seen happen at the OGS over the last few years is they're talking about the front of the eye. And I always say, if you're a glaucoma practice like myself in Pennsylvania, don't have lasers, I have an ocular surface disease practice because I've been beating the heck out of their eye with chemicals and BAK for maybe 15 to 20 years now, and I see the ramifications that it's doing. So we're trying to reduce that burden. The other thing that they've been doing is talking nutrition, which is good. It's kind of funny sometimes to watch allopathic docs try and speak nutrition, but it's still good because they're at least recognize it and discussing it. So what I want to do is kind of talk about some devices here. The eye stent, is where it all started. But now if you realize that there's a collector channel that is clogged, maybe if you put an eye stent in, it might not have worked so well. Because what happens if it was by a clogged collector channel? You put it in there, but you bypass the diseased trabecular meshwork, got the fluid into Schlem's canal, but now there's a clogged collector channel and you had a failure. So that's why now you can go in and you put these different devices in, and more can go in to the eye, and it's approved because to me, you're just increasing the chance of being by a viable collector channel. I forgot to connect the sound, but it'll probably play through my speaker here. So,
okay, here's a patient with refractory primary opening of glaucoma. Patients on 4 classes of topical medications, and pressures have been hanging out in the low to middle 20s. I'm entering the eye now
this is
with
Dr.
my
Paul
iStent
Singh. He's an
Infinite
ophthalmologist.
device here. I'm going to address the TM right across from my main wound. Gentle pressure, pressing the delivery button, holding, and then coming back out. I'm going to go 2 clock hours to the left here, using my wound as a fulcrum. I'm going to press that singulator, that purple button. I'm going to press that button to get the next stent ready to go, and then put gentle pressure, press the delivery button, and then come back out. I'm going to go 2 clock hours to the right now of that first stent. Again, same thing, press the singulator, get that next stent ready, put some pressure, press the delivery button, come back out. So now I have 3 eye stents into the nasal canal, 2 clock hours or so from each other. You see that reflux of blood? That indicates that we have probably some good access or good patency in the canal and the collector channels. Now watch that arrow on the right. Talk about blanching. Watch this. Look at this. Ready? The whole
right in here.
episcopal system wipes out. Now watch that blood vessel there with that arrow. Ready? Look at that fluid wave. Incredible. We go slow motion here in high mag. Watch that blood vessel one more time. Look at that fluid wave. Incredible. This is, I think, pretty unique. And we have 3 eye stents here. And I think it's important to recognize that we don't know what.
So my point is that, the diseased trabecular meshwork is what you're trying to get by. And luckily, where he put these eye stents, that the collector channels were open. And then what happens when he puts that BSS in there, you can see the veins clear out there because, and then they fill back up. So that just tells you that the aqueous is able to drain out. So, all right. So, what kind of just, I have a whole section on MIGS, where it all started with pharmacology was Durista. I always like asking the audience, in this 10 micrograms worth of delivery, how many of the 0.3 drops were actually in that Durista? It was actually 1. It was 1 drop, slowly released, and you could get 3 to 12 months worth of IOP control whenever it worked. And it just shows you like how good our ocular surface is when it comes to protection with the mucin and the tear film and glycocalax and everything. It's hard to get medication into the eye. And so that's why you have to use 1 drop every day or 2 drops, 3 drops. You just put this into the eye, 1 of this, and let it slowly release 1 drop over time. and you can get 3 to 12 months. And, it's only approved for one-time use, and that's because it wasn't biodegrading. So to me, if you do gonioscopy and it biodegraded and the patient needs one, and, 2 or 3 years later, there's definitely been there's been more than one put into an eye. If they don't degrade, you don't want them to be stacking up in the eye. So if you talk to a rep, they're going to tell you it can be done once, but there's been doctors out there that did it more than once and put it into the eye. It can be done in the office, at the slit lamp. That's the best part about this. And this is by Mataprost. That's where it started. Now, here's what I kind of wanted to show you, is kind of teeing it all up, what we're doing here with glaucoma. This is iDose with travoprost by Glaukos. It's 75 micrograms. And what we're doing here is it's a steel container that's been put into the eye, and it can last 3 months, 12 months, 81% of the patients. It's I have a doctor in town doing it. I've seen plenty of these, and it's amazing when you can get the medication into the eye and get that trabecular meshwork that is sick and get the medication to it and get it remodeled and the uveal scleral flow. It's amazing how low these pressures can go. So all I'm doing is showing you here, this is just a patient of mine. I have an anterior segment camera. You can see they usually try to put it right where the lid is so it can kind of cover it up because they are big. Some people can see it. I do have a slit lamp video here. I have a slit lamp camera that has video. And you can see here, that was the right eye. Here it is on the left eye. You can see they place some nasal in a sense because they usually make a temporal wound and go into the eye and just go kind of straight across and place it into the eye. And so here's a procedure of it being done. And you're just going to see a diamond blade knife here being, I'm not sure if there's sound on this. I don't think there is. Diamond blade knife. You'll see that they'll just, using the, gonio lens here for surgery, they'll slip this in and then they'll just insert it into that nasal wall. And it has a little, lack of a better term, a little spike on it. And they just put it right through and it eludes the travoprost slowly over time. Joe, any of the docs, I know you work in a med surg practice. Have the glaucoma docs or the anterior segment docs been doing this?
Our cornea and anterior segment people are not doing this. They might do an eye stent or canaloplasty. Our glaucoma surgeon does this, but he's been doing it really as part of clinical studies.
Very cool. Yeah, I've been pretty impressed by it.
I myself, because we're involved in the clinical studies, and they'll ask us to help and recruit. And it's actually, these I find to be a bit of a hard sell. Patients sometimes just fear going to the OR.
Yeah. So
Hey,
I think we get the point here, I think. Go ahead.
Before you go on, a question came in that is pertinent to this, and one is a little bit older. I'll do the older question first. It just came in. What flicker comparison software do you use on your camera, Greg?
Yeah, it's I don't know if I have a software. It's just built into the Aiden. So Flickr was out a few years ago, and I'll say 10 years ago. And I was in a study with it, and we were trying to determine if it would help with the progression of glaucoma and diagnosis and so on and so forth. And maybe it was a patent thing and it disappeared, but it's on the Iden camera. That's Glaukos. I'm not supporting anyone, not claiming superiority, so on and so forth. It just happened to be on the. It's just built into the camera.
Now, here's one that maybe we can both discuss. What's the first line of surgical treatment when a patient's on maximum medical drops and IOP is still not controlled? What are your thoughts there?
Well, it's going to be by the severity. If they're a severe glaucoma patient, they're maybe going to a valve or a trab. There's trab valves, there's bare valve trabs. That's probably a trip to Pittsburgh. No one in my area does them. If it's kind of still an earlier glaucoma and it's just, not controlled, and we're going to do, SLTs or maybe the person's asking beyond that. Now we're maybe going into Cahook dual blades or some of those, maybe a Zen would be more of an moderate type of MIGS procedure. So it's going to be based on the severity that's out there, whether it's a kind of a trap valve, bare valve type of situation, or whether it's going to be kind of MIGS with gonioplasties and Coke dual blades, or maybe a Zen procedure.
Yeah, we're a little bit more mixed. Trabeculectomy would be an option. I have seen a little bit with the AlloFlow, which is a suprachoroidal stent. Essentially, it's almost like I don't know if you've seen one, Greg. It's almost like a door stopper that's jammed into the the suprachoroidal face. That really didn't work, and my patient ended up getting a trab after that, and that worked. Um, yeah, you're right. It depends, but I think the question is, it's on maximum medical treatment and it's not getting down. I think probably what will happen is they might try something easy like an SLT or an iStent Infinity, but we're probably looking at a trabeculectomy.
Yeah, probably if I have them on 3 meds, I probably would have already intervened, because I don't like adding a second med or a third med without discussing with the patient about a laser. So that's why I would take that probably off the discussion. If they're on 3 meds, they probably already had an SLT, they're failing. Now we're probably going something more invasive. We good?
Oh, we're good.
Okay. So let's talk about Lacrophil here. This has been kind of cool. I've done this on about 7 patients now, and I'm 6 out of 7, I guess. One is like, it wasn't as good, but maybe I pumped it up too high on that one. But it's basically a nice little replacement for punctal plugs. Basically, put this fill into the upper and lower cannula. And it lasts up to 6 months. I tell the patient 3 to 6 months. And I started doing it probably right after AOA. So let's say August. So now I'm starting to get those people rolling in, and really getting some good feedback. So we don't really have to do that. Oh, let's do it. I kind of talked about, I guess I had it in the wrong spot. Lacrophil, have you heard of it? You performed it. I'm gonna learn about it tonight. So let's do the poll. Let's make it interactive. Let's
Greg,
make it synchronous.
the poll is not there.
Oh yeah, it says poll 3, poll. All right,
Oh.
skip it. We're good. All right. So Lacrophil, improves Schirmer, ocular surface disease. It's out there 3 months, 6 months. Everyone wants to see the science behind it. Pretty cool procedure. I'm just going to kind of show you how it comes in the office, and here's the procedure that I did. When I get this up here, you'll see that, I think I dilate. I haven't watched the video in a while, but I've done enough of them. You dilate it, you kind of bend it over. And then most of the patients that I've done, you just kind of fill it up until you see it kind of regurgitate. So it goes through the lower, fills up a little bit of the sac, and then kind of fills up the upper and comes out the upper. And then you could stop. But let me just show you this video first. I turned on the sound when I flipped off so you can kind of hear everything.
The Lacrophil.
You have to get these little disposable you could probably get a one that you can. It's a 25 gauge. You don't want to go too small because it's thick. So you don't want to go too small. It's got a little bend to it.
The key here is getting this on.
They told me what to order whenever I bought them, and I was just able to have my
We're gonna push, see if we can get out a little bit.
technician who does all the ordering. So you just kind of prime it, push it out. It comes out, little gel.
We're primed and ready to go.
So that's building it. So you're going to see me. This is how quick it is. This is how I did it in the office. I don't think I spliced anything here. Dilated the puncta. You'll see me come in. You'll see the bend to the cannula. We'll put it down in, kind of get past that. Now I'm in. I kind of go back and forth a little bit just to make sure I'm not up against a wall of anything. And I think right now you'll see it kind of the carbuncle start to fill up too. You'll see it kind of bulge as I'm pushing here. And this is, see, it's coming out the bottom here, regurgitating. And it came out the top. If you look right there, some came out the top. So now this whole area is filled. You can see the lower's filled. And what patients have said, they felt a little discomfort the first day I've done it. And then after that, they're just thrilled by, not having to use drops. They got this, uh, whatever the fill is, the lacquer fill, if it's here, whatever it's made of, kind of oozing out, keeping the tears on the eye. If they're using any type of the drops or on there for a little bit longer periods, it's hyaluronic gel right here that is melting and keeping that eye nice and comfortable. So I just thought I would show this here. I texted my patient. It's Joy. It says, Happy Friday. How does the eye feel? A little discomfort for about an hour, just slight irritation at the bottom. Vision good. Put my vital tears in. She's a Sjogren's patient. Okay, keep me updated. I will. Irritation lower went away last evening. The eye feels good. Put vital tears in 2 times this morning. Skipped the noon steroid drop. Definitely feels better. I wrote thanks, thumbs up. And then here, my eye hasn't felt this good since I used Oxervate, using minimum amount of drops, ready to use the other eye. She was just in the other day for follow-up. She's like, nope, still doing good. I don't need my refill. I wrote fantastic. Oh, I didn't write that. When she was in the other day, I said, fantastic. We'll see you back in 3 months. Call me if you need a refill before that. And then right here, fantastic. I'll see you tomorrow or whenever your next follow-up is. So it was great to be able to do this. This is the rheumatologist right down the road from where I work. He texted me and said, hey, Greg, had a mutual patient. I don't think it's her because I've done about 6 of these, 7 of these now. And so he said, hey, Greg, he's a rheumatology. He really gets eyes. So I try to refer to him a ton because they're all good over there, but he did an eye rotation. And he wrote, mutual patient with Sjogren's underwent some type of procedure in your office where he injected some new RX into their tear ducts. It worked great. And I wrote, happy Friday, feedback. Thanks for the feedback. Relatively new procedure I've done. Several patients, similar results. Lacrophil, blah, 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 blah. He wrote strong work. So kind of us kind of tag teaming these is pretty fun. And there's all kinds of billing on it. Just let me just do this real quick, Joe, and then I'll answer it. You could bill all 4. It's basically punctal occlusion, whatever that code is, 992 something. It's probably in here somewhere. But go ahead, Joe, ask your question. Basically, you just bill it as punctal occlusion.
You're actually answering it.
Okay, so it's right here. What is the Medicare reimbursement to the physician? You bill it under 68761. I bill all 4 of them. If it comes out the upper, if it doesn't, I go and put it in the upper, and you can bill all 4 at one time. You just have to it's all written out here by the Corcoran Group, and it tells you what modifiers to use, and you just bill it under dry eye. Did we answer it?
Yes.
Okay. Let's jump into the last one here. Let's talk about the presbyopia drop here. There's a lot of confusion in the market. Again, I'll tell you that I'm a speaker with Lens. Again, just as a reminder out there. Not that I'm promoting it, but I understand the drop really well. But I also understand pilocarpine and carbachol drops really well because whenever I was at PCO over the years, I used a ton of pilocarpine, up to 6% to manage glaucoma. And that's really the difference is pilocarpine and carbachol. There's what's approved right now is Vuity and Closey. When I was at the academy, I met with a company that's 10-point. They're coming out with the carbachol with a little bit of bromonidine in it. And there's the non-pilocarpine based, and that's what Viz is, the aceclidine, and that one's the one that's recently approved, and a lot of dinner programs being done. It's preservative free along with Closey, and I think we're all familiar with Vuity. It's been out for years, so remember, these are used as glaucoma meds so they can pull on the ciliary body. Aceclidine was developed in Europe to be a glaucoma med, was a bust, was terrible, didn't work. And so, but they're all miotics. They all create the pinhole effect, if you want to say. They shrink the pupil down. Aceclidine gets it to what they call the sweet spot, less than 2 millimeters. I was taught at PCO by Chuck Wormington that the optimal pinhole size was 1.88. So we're kind of getting down to that optimal pinhole size, but we're sparing the ciliary body out there. We don't have to do the polling question because we have about 9 minutes here. We have, lens therapeutics. This was approved. It's a new mechanism of action. There's a twist to the mechanism of delivery. It's a new kind of material. That's why it stings, because the pH of it is 4.8 to 5.5. And it has to be an acidic solution, because if you raise it up, it starts to crystallize. They call it dosing. You put a drop in, you wait 2 minutes and put another drop in. You're getting that pupil less than 2 millimeter size. It's not magnification. It's not like plus 150 or plus 2. It's not magnification. It's clarification by squeezing the pupil down and getting that increased depth of focus. They're only going to focus on the eye care practitioners that are out there. The mean on this, they tested, when in the studies, they had pseudofakes, post-LASIK, RK. The mean age or the maximum age for Vuity in their study was 54.5. And here they did 45 to 75. So their maximum age was 55, or you could say 54.5. Here they did a range for aceclidine 45 to 75. The mean age was 55. So their mean age was 55 and the maximum age. So you can't really compare the two. When I do this live, and I did it in Detroit, people are like, oh, this is for your emerging presbyopes. Nope. And that's because we're still putting it with the first to market. This is a wide range. Pseudofakes, LASIK, 75-year-old, 45-year-old, that's out there. So I would, it's not going to replace bifocals and progressive and contact lenses. I had someone say, I'm not going to prescribe. It's going to kill my business. And I'm like, all right. I've already had people come in because I've already helped people out, and they're referring people to me to try the drop that's out there. I don't think it's going to kill our progressive and our multifocal contact lens business out there. It's just another tool in the toolbox. When I was being trained on this, I said, there's got to be hyperemia. Phenylephrine constricts the blood vessels and dilates the pupil. Pilocarpine is a miotic, and it's an anticholinergic. So it's got to create redness. And they're like, no, the study showed here that 15 and 13. So I went and talked to the medical science liaison, and it was because they tested at 30 minutes. That was their first test point. Then I talked to people that were in the study, and they were like, hey, Greg, we put the drops in, we followed the protocol, and then we went and saw a patient. We weren't supposed to be really looking at them at 2 minutes. So that's why you'll see redness. You'll see that it burns. People will see their floaters because it increases the depth of focus. It puts that point back to where the floaters are. People might get a headache or some brow ache. It's not a headache. It's not a pilocarpine headache. And really, over about a 7-day period, it becomes transient and then gone by 28 days. Here's really the kicker. This is how you realize that it is pretty much ciliary body sparing. When it comes to this here, understanding iris sphincter 50 EC, basically how much medicine does it take to constrict or create a muscle contraction by 50%? For aceclidine, for the iris, it's all about receptors. This is very specific for iris receptors, not for the ciliary body. It takes very little medication to create the iris sphincter to constrict. And when it comes to pilocarpine, it's 1,800 units. To get the muscle to constrict in the ciliary body, it's 25,020. So it shows you it needs a ton of medication over here to get up to 50%, but it doesn't take much. So it's very iris sphincter specific. Over here, you can see that the pilocarpines and the carbacols for the same thing, they do target, they need a little bit more medication, but it's a 2-to-1 ratio. This one's 28, this one's 22. They even went lower and said 20. So about a 20-to-1 ratio. So it doesn't hit the ciliary body. Now, here's some more science that's out there on this. When it comes to the myopia with Viz or aceclidine, you get 0.17 diopters of myopia. How about lens shift? If the ciliary body is constricting, then the lens should shift. Well, it shifted 0.78 millimeters. How about lens thickness in the phakic patients, right? Not the pseudophakic patients. In the phakic patients, the lens thickened by 0.07 millimeters. Pilocarpine had a 1.3 diopter. The lens shifted by 0.23. So if you move something plus forward, yes, you get myopia, right? You slide down your lens. You take a high minus person that's minus 14. They don't need a bifocal. Just have them slide it down a few millimeters. They gain plus. So when it shifts forward, they gain plus, and that's why they become myopic. You can see no lens shift here, 0.2 millimeter increase in lens thickness. So it comes in 25 vials. You do 14 refills. It's through UpScripts. You can get it through the local pharmacy. It's HSA and FSA eligible. It costs $79. There's no insurance involved. Talk to your reps. I just wanted to bring it to you if you're interested. It works well. Once a day, lasts 10 hours, 3 lines of vision. So I actually made it to their slide deck. When I was at the academy, I was playing around, and in their slide deck that they do at dinner programs, this was baseline. This was before I put it in. This is day 1. Look how red. I knew it was going to get red. It's pharmacology. It's an anticholinergic. But this is 15 minutes later. This is a half hour later. But by day 4 and 5, so this is 30 minutes after installation. First day, I think I have this labeled wrong. Sorry. This is day 4. This is this is time 0. This is day 4. This is 15 minutes. This is a half hour. So if you grade at a half hour, you would call it, just like they did in the study, mild hyperemia. So here's a patient that had it done in the office. I just put it in. This is 2 minutes after. You can see how red she is. But this is how you do it. So they give you these things. You check off before you put it in where they are. And
All right, so here we are. It's not anywhere close to a full half hour. We just put these drops in. This is where Erin is.
it's about 15 minutes.
She's internet. She's social media. Her eyes are red, as we can see here.
So you check off where they are. I had her hold it without any glasses up close. You hold it there. She's like, yeah, the only thing I can see is right here. And then watch what happens.
We're going to hand her this. And where are you?
Wow. So I can read the bottom line, credit card, free print, fine print, sorry.
Oh, that's
Definitely.
pretty. So you're down here.
Smartwatch text, standard cell phone text, tablet e-reader text, all the way up.
And you said that was...
That was even fuzzy when we started.
Very cool.
So, very impressive.
All right.
So they're going to get some dimness. I get dimness whenever I use it. Pupils are small. I brought her over to the computer because she wanted to know about the computer.
All right. We're having such a great outcome here. You're excited because you're not going to
have to have my readers in my purse, in my car, beside my bed, on the kitchen counter.
And come on over here. We just did this a little bit ago, but here we go. We got the fine print.
It's got wheels. Okay.
She slid a little
bit. So
bit.
I can read everything on here, hand scanned, active ophthalmolic, neomycin, everything, drawing the tiniest
cool.
print.
Very cool.
So it works. So I'd say try it. They're sampling like crazy.
Okay.
That's out there. But I think we're right at 9:50. Just let me do 1 minute here. I just want to talk about just real quick with Triptyr. It's one of the newer medications that's out there. And what this is doing is it's triggering this receptor on the cornea where it's cold, and it's hitting that lacrimal functional unit. The lacrimal functional unit is the cornea, the conjunctiva, the lacrimal gland, the goblet cells, and the afferent system and the efferent system. It's this whole neuronal network. And basically this medication is targeting and going after basal tears. Tyrvaya, what it did is it created reflex tears. Basal tears are better than reflex tears when it comes to treating dry eye. This medication has been shown to increase Schirmer testing, decrease cornea staining and conjunctival staining, and it's also shown that it has improved patient systems on the visual analog score that's out there. What I want to point out, why I want to talk about this is the cornea stuff, is that right now I have tried it on about 25 patients. It's because their first refill for whether it's Medicare, Medicaid, or commercial is free. So when that happens, what I try to do is figure out where this is going to plug in, take advantage of it, because then I'm going to learn where I want to use it. Now that I've been using it, I have moved it up on even the mild dry eye patients that are out there, because it is actually, it stings when you put it in. It's neuronal. 50% of the people complained about pain. It's more of a menthol. It's not like if you put in your mouth an Altoid versus a Fireball, it's kind of different. It's not a pH burn, because the pH burn of it is, the pH of it is 7. But what it does is it's more of a menthol, but it goes away pretty quickly. I've used it because I show the patients in the office how it's going to sting, because it's 50%. And I put it in my eye, and my eyes feel pretty good because I'm on the computers when I'm at work. So try it out. It's Triptyr. It's for dry eye. It's for signs and symptoms. It's approved for the signs and symptoms of dry eye disease. It's a Culturemon by Alcon. Reach out to your local rep. You have to rethink it. It's not an immunomodulatory. It's not just replacing the lipid layer. They have shown in their studies with that neuronal expression that it does cause the lipid layer. So it kind of works well with MIBO, in my opinion, that's out there. So take a look into Triptyr and Acoltramon for the treatment of dry eye. All right. We should be pretty close and be done here to respect people's. So we could do number 7 here. I'll launch it. I just want to see if you picked up a few insights tonight. That poll was open. Joe, are there any questions as we're going to wrap up? We'll be done by 10.
Nope, we're all good.
Okay. So I picked up a few insights on latest innovations tonight. Yes or no? A really simple one. Let's make it interactive to the end here. Let's make it synchronous since I skipped a few questions. And it looks like the polls are rolling in nicely. And we're getting a nice response there. I'm hoping, yep. All right. So we're not going to make it go too deep because we have a 10 o'clock deadline here. I can see it. Glad it worked out. It's not my traditional lecture. We like to do a lot clinical. This was clinical, but more of an innovation lecture. So perfect. All right. So that little button is up there. It says survey. I can see it. You can start that survey. And I think Joe said that there's no more questions. So with that said, I want to thank everyone for attending. This was latest advances in eye care technology, innovations in early detection and management. I was your speaker tonight. Joe, thanks for manning the polls and manning the questions. That will conclude the CE.